Okay, so blood composition. What's in it for me? We have to think about what that is when we pull a tube of blood out of a patient, and or what it is that's coursing through our blood vessels at any given time. Probably one of the easiest ways for me to think about that is like I've drawn a tube of blood from a patient. What happens to it next? They send it to the laboratory and they spin it in a centrifuge. And when they spin it in a centrifuge, it divides, like you see here in the picture. The formed elements, meaning the cells, and the platelets drop to the bottom, and the plasma, or what blood floats in, goes up to the top. And so you can see that, generally speaking, about 45% of what's in a tube of blood is formed elements, and about 55% of that is plasma, meaning the stuff that the blood floats in. We also call plasma serum, so that if you've been in the work environment and they say, we're going to run a serum digoxin level, or we're going to run a serum dilantin level, they're speaking of what is that level of drug in the serum, in the plasma. Okay, so those words are kind of synonymous, serum or plasma, that which the formed elements float in. And then when we break that down, in our formed elements, we have erythrocytes, which are red blood cells, we have leukocytes, which are white blood cells, and we have platelets, which are fragments, which are necessary for forming blood clots. And then in our plasma, 90% of that is water, right? And we've talked about in other classes the effect that water or hydration has on blood values. Okay, if a patient has too much water or they're in a state of fluid volume overload, that could make our hemoglobin and hematocrit look a little bit lower than it actually is. And we call that a dilutional effect, in that we have a little bit more water than usual, so our H&H might look a little bit lower. Vice versa, if the patient is dehydrated in a state of fluid volume deficit and their overall water level is down, it might make their H&H, hemoglobin and hematocrit, look a little bit higher than it really is. And that's a patient that is experiencing fluid volume deficit or dehydration. All right, another huge component of our plasma is albumin. And I've alluded to that in other classes. Albumin, that protein which is created by the liver, is necessary for maintenance of oncotic pressure in our blood vessels. It provides the pulling pressure. It helps bring fluids back into the vascular space. So if we are deficient in albumin, the patient will have difficulty maintaining vascular stability. The fluids will tend to leak out into the tissues and stay there because there is not sufficient oncotic force on the venous side to pull those fluids back into the vascular space. Other things that you're going to see floating around in the serum: electrolytes, waste products, gases, and so forth. So this is just a nice slide that shows what's in it for you, all the different components, parts, and pieces. And of course, they all have important functions. Now, when we look at the blood cells themselves, starting with erythrocytes, that's our biconcave cell. And remember, that cell is wider than a capillary. So in order for a red blood cell to go through the capillary bed, it has to twist and contort. So can you imagine that if a red blood cell was diseased, such as in sickle cell anemia, that there would be difficulty getting those red blood cells through the capillary bed, that they might get jammed up, they might form a clot. So erythrocytes are actually wider than the vessels that they have to travel through in the capillary network, and they must contort. What is their purpose? The purpose of an erythrocyte or red blood cell is to carry oxygen, and in some degree to remove CO2 from the body. So if we have not enough red blood cells, we will have, generally speaking, not enough oxygen. We will have a state of hypoxia. And that doesn't matter how healthy the individual is. It can be any of us, healthy individuals. If we have a deficient number of red blood cells, we will be hypoxic. We can die. Our organs can die. They can be stressed. All right, platelets. Platelets, the other name for them is thrombocyte, and that means cell that forms a clot. So if a patient is thrombocytopenic, that means low numbers of clotting cells, they're going to be at high risk for bleeding. So we watch that value very closely, and if the patient drops, we may be putting them on precautions for bleeding. If a patient has a platelet count very low would be 10, 20,000, those patients can just rub their eyes and form spontaneous ecchymosis, spontaneous bruises, like raccoon eyes. So platelet count is very critical when we talk about being able to form a blood clot is necessary. Some patients will get a really high platelet count. You'll see that sometimes clinically. It's highly associated with chronic illness, long-standing illness, and they'll maybe have a platelet count of 500,000 or 600,000. Not horribly significant, but if it goes too high, they're at risk of spontaneously clotting, okay? Now, the white blood cells are all of these remaining cells that you see on the slide. The one that's probably most important for us to know something about would be our neutrophils and our lymphocytes. So let's start with our neutrophils. Those are our major white blood cell that elevates in response to infection or inflammation. So if I'm taking care of a patient who has urinary sepsis, an infection in their urinary tract that goes to their bloodstream, I better see an elevated overall white count and an elevation in the neutrophil count, because those are the infection fighters that are going to protect me. They're going to engulf and eat the bacteria. Now what's interesting about those is that they generally only live about 2 days. And in the face of a very significant infection, they may only live 4 to 6 hours. Okay? So if the neutrophils are fighting a really horrible infection, their numbers may drop significantly. And what we might see next is a proliferation of bands or stabs. And those are the baby neutrophils. We talked about this in simulation, just to refresh your memory. If the patient has an infection that's so significant that all the neutrophils drop, and we see an elevation in bands or stabs, which are babies, we call this a shift to the left. That is a shift to the left. The way I remember it is that we are only having what's left in the bone marrow to fight our war. Only the babies. Think of it this way. We send our mature soldiers, our neutrophils, out to fight the war for us. But if they all get killed, well, we're going to send out the kids. That's all we have left. They won't fight as well. They won't be as well prepared. But that's all we have. So we're going to send out the youngsters, the bands and the stabs, in order to do what they can. That's considered a shift to the left. The doctors will write that on the chart. It is not good. That is not a wonderful situation for the patient to be in. It usually is a patient who's already on 2, 3 antibiotics. It's a grave situation. We don't like that. All right. Lymphocytes usually elevate in response to viral infections. All right, and we have 2 kinds. We have T and we also have B. Probably what you're most familiar with, one of the T cells is a CD4 cell, a helper cell, and we see those cells drop out in the face of HIV infection. Okay, when the CD4 count drops below 200, we consider that AIDS, and the patient then becomes at risk for nosocomial infections, okay, infections that we normally wouldn't get. Okay, opportunistic infections maybe is more referred to. So that's an example of a T cells. There's also killer T cells. There's several different T cells. And then you have your B lymphocytes, and those are the ones that make antibodies. Okay, antibodies to fight off particular antigens or viruses or things like that. So when you see that lymphocyte count go up, think viral. So a good example would that be maybe your patient that's admitted with the pneumonia. Could be viral, could be bacterial. If it's bacterial, which cell do you think is going to be more elevated? Neutrophils. If it's viral, which cell is going to be more elevated? The lymphocytes. So you can use that data to help you zero in on the main culprit for infections. Is it viral? Is it bacterial? All right, we have a few other white blood cells that may or may not be helpful in analyzing what's going on with our patient's condition. Eosinophil is a cell that is related to allergies, and I was just going to point you to the E. In my mind, When I think of an eosinophil, I think of allergy. I think of that big E, allergy, eosinophil, and the other E sound that goes along with that is immune globulin E. All of those things elevate when we have a patient that has an allergic reaction. So eosinophils, okay, goes along with allergy, goes along with IgE. All of those sounds help me remember that that's an allergic type reaction. So if a patient's experiencing anaphylaxis, okay, or poison ivy, or some sort of allergic type response, you're going to see an elevation in eosinophils. Monocytes circulate in your bloodstream and when activated become macrophages. And those are your phagocytic cells that respond to eat up and engulf bacteria. Basophils, we don't know a lot about those, except that they're full of granules like histamine. They are similar to a mast cell. When activated, they cause symptoms like watery eyes, runny nose, leaky capillary beds. Okay? So which ones do you think are most important for you as a nurse? Erythrocytes, neutrophils, lymphocytes, platelets. Those are the ones that you're looking at in your CBC report. We did talk about one other lab value related to a baby red blood cell. Does anybody remember what we call a baby red blood cell? Reticulocytes. So you might be looking at those values. They're not included in the regular CBC report. You would have to order that lab separately if you wanted to know about the status of red blood cells in production at any given time. So let's say the patient has had a hemorrhage 2 or 3 days ago. Okay, what would I expect to see in the reticulocyte count? It should be high. There should be production of baby red blood cells from the bone marrow, and they should be being spit out a little bit early in order to meet the need. What if I don't see that? That's a problem, and it's probably got something to do with bone marrow suppression. The bone marrow is not responding properly to a drop in erythrocytes. Okay. Don't get confused trying to look at this. I only put it up there for one reason, and that is all of these cells at the bottom of this chart are formed from one stem cell. The reason I put this up here is to talk about stem cell research and the fact that many things can go wrong in the differentiation of these cells, all right? In between the stem cell and the production of erythrocytes, neutrophils, platelets, and all of those other things, we can have things go wrong. That's where people can develop leukemias, lymphomas, and things such as that. Now, what's the beauty of the stem cell? It's the baby that can become everything else we need. That's being researched. There's a lot of research going on with that, and there's a lot of controversy about whether that's ethical and whether that's okay. I'm not going to get into that discussion. I just want you to see the slide and understand that the one stem cell becomes all of these other things with proper stimulation. This can be a very helpful treatment in the future, but it is a very talked about issue right now and is surrounded by a lot of ethical controversy.
Are those stem cells housed in the bone marrow? That's where blood's produced?
They're most prolific when you're born, if you know what I'm saying, and that's why there's a movement to preserve cord blood. That's your best chance at getting a supply of stem cells for yourself. So yes, they can be harvested from bone marrow, but the best way to get them for later use is to retain cord blood. And that's why there's banks that are offering that service now. When a child is born, the mothers get information about, would you like to bank the cord blood? And that is the best way to preserve stem cells for that individual for later in life, and or a sibling. Okay? It's a whole issue. I just bring it up with this slide so that you understand the benefit of a stem cell and what it can do. Does that help you understand? That picture helps you understand, but don't memorize it. You don't need to. I just put it up there to talk about that particular concept. All right, holy hemoglobin. Hemoglobin is very important, and you don't need to memorize this picture either. The significant fact is you need hemoglobin to carry oxygen. If you have it, great. If you don't, it's very bad. It enables blood to carry 100 times more oxygen. Pumping iron. You need iron in order to form blood. Okay? Iron is a renewable resource in the body. When red blood cells are broken apart, iron is liberated and it's taken by albumin back to the liver and stored. And that works great, unless the patient has a slow leak of blood somewhere. If the patient has, for instance, a GI bleed and they're losing a little bit of blood every day, then what happens to the ability to recycle the iron? We decrease that ability or we lose that ability. So if we have a patient that has an active blood loss, they're not going to be able to recycle and store iron for blood production. So what do you think one of the most common causes of iron deficiency anemia is? GI bleeding. Okay? So iron is a renewable resource. We need it in order to form blood. Many of patients that are anemic are going to be put on supplemental iron whether they think they need it or not. Highly associated with GI bleeding. It's associated with other things as well, but I like to put that little idea in your mind. Erythropoiesis, that is the process of production of red blood cells. So it's important to understand, how does it happen? What is it that causes the production of red blood cells in our body? All right, there is a hormone that is secreted by your kidney, and it is called erythropoietin, and its target is what? Its target is the bone marrow. Okay, so the kidney, in response to low pressure, in response to not sufficient perfusion, will secrete erythropoietin. That's one of its jobs. So when we go through kidney, we'll review that again. It's one of the jobs. Its target is the bone marrow, and we hope to see the release of red blood cells. Now, if a patient has kidney failure, are they going to make enough red blood cells? No. All renal failure patients are anemic. But we have the ability to simulate and recreate this in the body. If the hormone's not being produced, we can give it as a drug. What's the name of the drug? Procrit, Epigen. That is a synthetic erythropoietin. We can give that to patients who have renal failure and other types of anemia to stimulate their bone marrow to make red blood cells. That's how it's supposed to work. To clot or not to clot? That is a very important question for nurses. And in which state might your patient be? Most of the patients that are in the hospital, we are worried that they are going to clot too much. What types of things predispose a patient to clotting in the hospital? Surgery. If you are cut on, that stimulates the clotting cascade. What else? Sedentary, sitting in one place, laying in bed. That stimulates the clotting cascade. The immobility. Pregnancy. Pregnancy stimulates the clotting cascade. Smokers. Is that a direct? I'm not aware of that being a direct correlation. It does not help with
birth control pills. Yeah.
Birth control pills stimulate the clotting cascade. No question about that.
They say you definitely shouldn't smoke when you're on birth control pills.
That increases your risk of vasoconstriction, I suppose. If you're vasoconstricted, that might influence it. There is a direct correlation between birth control pills. I'm not sure about the smoking. I have to look into that one a little bit further.
What about that?
Diabetics, they seem to be at risk for everything. I'm not sure if that's a direct correlation on the clotting cascade. The smoking, the diabetes, those certainly contribute to the development of atherosclerosis and coronary artery disease. That's for sure. So our patients that are in the hospital are at huge risk of developing clotting issues. And what is it that we do to try to prevent that? Ambulations, the sequential compression devices, pneumatic stockings, TED hose, drug therapy such as, what do we stick in their stomach? Heparin or Lovenox subcutaneously, aspirin. Okay, all of those types of things prevent clotting. Now remember, clotting is necessary to save our lives. If we are cut, we hope that we clot so we don't bleed to death. That's really important. When we think about the other side, as far as a patient maybe being at risk for bleeding, we need to think about the components that are necessary to make a clot. We need healthy blood vessels, we need sufficient clotting factors, and we need platelets. So if a patient is deficient in any of those items, they're at risk for bleeding. A deficiency in clotting factors is called hemophilia, and there's several different kinds. I'm not going to talk about them in this class. Simple patho. They don't have a clotting factor, they have hemophilia. How do we treat it? We give the factor. Simple as that. Platelets. If for some reason the patient is deficient in platelets, they're going to be at risk for bleeding. No questions asked. It's going to be a problem. If they're on blood thinners, plus they're deficient in clotting factors, plus they don't have platelets, I'm going to have a bad day. That's going to be a bad day. Okay, cleanup crew. Remember that all of the clots that are formed in your body are created in order to stop you from bleeding to death. That's what they think they're doing, responding to injury and keeping you from bleeding to death. And the normal process of clot breakdown happens in a couple of days. The clot is formed, it's supposed to do its job, and then in a couple of days it's supposed to be eaten up and removed. That's the normal process. Okay, that's what's supposed to happen. And we know that in disease a lot of times it doesn't. So cleanup crew is supposed to come in, lyse and break down those clots in a couple of days because you don't need them anymore to keep you from bleeding to death. That's the way things are supposed to work. All right, now let's talk about problems. Okay, let's talk about anemia. That's probably your most likely state board hit, would be something about anemia. Why? Because we see it all the time. Now when you're prepping for clinical and you're taking care of patients and you have that low hemoglobin and hematocrit, knowing that your patient doesn't have enough blood, you can tell me that they're anemic, but I already know that. The question is, why? Why are they anemic? That's what I want to know. That's what I want you to know. Because if we know the cause for their anemia, we might be able to give them the proper treatment. Otherwise, we're just dealing with a chronic anemia and we don't know why. Okay? So the question is not, they're anemic, it's why. There are many words that are used to describe anemia. I do not suggest that you memorize these at all. I want to tell you what the words mean in case you see them. Don't memorize them. It's not of use or benefit to you. You really don't need to. All right? So these words refer to cell size, that's the red blood cell size, and the color. Macrocytic means it's a big red blood cell. Microcytic means it's a little red blood cell. Normocytic means it's a normal sized red blood cell. Fine. You don't need to memorize it. Okay? Chrome has to do with color. Hemoglobin provides color, right? So when they refer to normochromic, it means it's normal color. If it's hypochromic, it's less color, and we don't have hyperchromic listed as an anemic profile used most of the time. So don't worry about memorizing the words. You're going to see anemias described that way. It's not really sufficient or helpful, necessary or helpful for your understanding as a nurse, shall I say. Not necessary or necessarily helpful, other than to know what they mean. Anemias will be referred to clinically by their name. That's what you need to know. That's what you're going to see on state boards as far as the name of the disease and the patho. That's much more likely what you'll get. So let's talk about the different types. Pernicious anemia. This is very common in elderly females. Okay? It has to do with a decreased production of IF, intrinsic factor in the gut. Okay? We need intrinsic factor in order to absorb B12. So if we don't have intrinsic factor, we will not absorb B12 and the patient will become anemic. This is the elderly female patient that comes in once a month to get a shot of B12. That pinkish red stuff that you have to give Z-Track IM. Now, why is it that we have to give it IM? Because that is the way it has to be given.
Sub-Q.
We can give it sub-Q. It's not usually recommended. Why can't we give it oral is the question. They can't absorb it. We can give them B12 all day long as a tablet. They won't absorb it because they don't have intrinsic factor. Exactly. So they're going to get B12 intramuscularly. There are some patients who have a folate deficiency. Both of these B vitamins are necessary for blood production. If they don't have it, we give them oral folate. And are you start to see the profile? If we don't know why a patient has anemia, they start giving them everything. B12, folate, iron. Let's see if anything works. Throw the spaghetti. Does anything stick to the wall? Does the patient respond? And then if they want to figure out which one thing it is, they start removing one thing at a time. Or they add one thing at a time. All right, other types of anemia: microcytic, small cell, not so much hemoglobin. Iron deficiency. What did we say is highly associated with iron deficiency anemia? GI bleeds. Do you remember why? If you are bleeding, you are losing your blood with the iron in it. You lose the ability to recycle the iron, thus iron deficiency anemia. Now there are some times in your body when you have an increased iron need, and that can stimulate iron deficiency anemia. Or we might see it in children or infants who have immature blood production systems. Those are other potential causes. We don't see thalassemia very much. This is a genetic type of anemia. So and the hemoglobin is impaired. It's not formed properly. The protein is not formed properly. And the body sees those cells as foreign and munches them up, eats them. So thalassemia is not real common. I would want you to know much more about iron deficiency and pernicious anemia. That's what you're going to see on boards. All right, now there are forms of normocytic, normochromic, and hopefully this will make sense to you as we discuss them. Aplastic anemia, what that means is, A means no. Plasia is growth. So an aplastic anemia means there's no growth. So that would be a situation where the bone marrow is suppressed or not stimulated. In renal failure, is the bone marrow suppressed or not stimulated? It's not stimulated. In an autoimmune, what's happening? It's suppressed. It's being attacked by your body. For some reason, your own body sees your bone marrow as foreign and starts to attack it. So aplastic anemia is when there's no growth. What would be another thing that could cause aplastic anemia? Chemo. And that would be that your bone marrow is suppressed. Okay. Hemolytic anemia. Remember hemolysis, the word means breakdown of blood. Hemolysis. Lyse means breakdown. So if we have hemolysis, a common cause for that would be a blood transfusion reaction, where you're given the wrong type, the wrong Rh factor per se, and then those cells are attacked by your immune system and all the cells are broken apart. When they start to release their components, we have a lot of free bilirubin. What sign or symptom will you see in a patient with hemolytic anemia? It's common that you might see jaundice. So jaundice, we often associate that with liver disorders, but it can be related to hemolytic conditions or hemolysis of blood. Where's the best place to assess for jaundice? Eyes. Sclera of the eyes. Consistent in all, not dependent on looking at skin color for diagnosing jaundice. Hemorrhage. If you lose blood, that could be a cause of anemia. Sickle cell. Okay, in sickle cell anemia, that can be a cause. We'll probably try to look at those slides if we can. Sickle cell's genetic. It's autosomal recessive. You have to get the gene from both parents for it to present. I'm sorry?
They can't hold the hemoglobin, correct? So
the hemoglobin is the protein chain is missing one amino acid. One amino acid causes that loss of 220 per se, causes that disease. It's amazing that anything ever works right in the body. Really. It really is amazing. Okay. This shouldn't freak you out either, but this is the kind of stuff that you need to know most as a nurse. What does it look like when a patient's anemic, or has anemia? That's what this slide is about, and that's what you need to know as a nurse. Without even looking at a lab slip that says their H&H is low, which lets you know they're anemic, but not why, what will you see when you look at the patient? They're going to be pale. Are they going to think well? They may not think very well at all. When you sit them to the side of the bed, they might feel dizzy. They might wobble a little bit. If you were to check their blood pressure, lying, sitting, and standing, they might show orthostatic changes. Okay, those are common things. When you take their vital signs, their blood pressure will probably be low. When you check their pulse, it's probably going to be high and thready and weak. When you assess their respiratory rate, it's going to be high. Okay? Those are the types of things that you're looking for when a patient is anemic. You should be able to pick up on that even without the lab slip, but the lab slip is going to confirm it for you. And or if you look at your lab slips before you assess the patient, then you've got something in your mind and you're going to confirm whether or not that patient is symptomatic. Yes? What's the magic number on the hemoglobin that you've all been exposed to now is 8. If the patient's living around 8 or drops below that, I want you to be worried. That's a great marker. If you're treating that patient for anemia and you're giving a blood transfusion and you give 1 unit of blood, what should happen to that hemoglobin? It should go up 1 gram for every 1 unit of packed RBCs. That is so helpful.
Mary, what's the EPG?
What's
EPG in cells? It's elevated. It's on the right.
It's
very right-hand side.
It's defined here. Diphospho, I can't pronounce it.
Very right side.
A substance which helps determine whether or not your hemoglobin holds more oxygen to itself or releases more oxygen to the tissues. I can't pronounce it, but it is here on the slide. What it has to do with is how easy is it for oxygen to be released. And when we have anemia, the blood cells will be more likely to give up their oxygen. There's a shift in the oxyhemoglobin dissociation curve. Okay? Not necessary that you know what that substance is. The concept is that substance helps release more oxygen from the hemoglobin. That's the concept.
So if it's elevated, it's releasing more, or helping to release more.
Right. More oxygen is liberated to the tissues. Like I said, don't memorize that slide. Understand what your patient will look like. That's the key factor. Now, diagnostic tests for anemia. This helps us understand why, the cause of. All right, we'll do that CBC. That'll confirm anemia for us. We might do a Schilling test. Now, this is going to make me be able to ascertain whether or not you understand pernicious anemia. Okay? The Schilling test is done to confirm whether or not they have pernicious anemia. They are going to give the patient an oral tablet of B12 that has some radioactivity in it. Now, if the patient shows up with radioactivity in their urine, do they have pernicious anemia?
Yes, they're not absorbing.
You have to think about how the tubes are connected.
No.
If you take a tablet with radioactivity into your gut,
It would come out in their feces, not their urine.
if they have pernicious anemia, it will come out that side, not this side. Okay, so let's go through the thought process again. You take a tablet with radioactivity on it. And if you have pernicious anemia, you will not be able to absorb it. Your urine will be clear. There will not be any radioactivity there. That's a patient with pernicious anemia. It's all going to come out in the stool. A patient who is normal is going to take that B12 radioactivity, absorb it, and pee it out. That's normal. That's a normal patient. They absorb it. That means they have intrinsic factor present. One more time. Patient takes radioactive tablet, B12. They absorb it from their gut into their vascular system. It gets cleared by the kidneys. They pee it out in their urine. That's normal. Okay? That's normal. If the patient takes that radioactive tablet and their urine doesn't have any radioactivity in it at all, that patient has pernicious anemia. All right, we can do serum levels. Remember, that's looking at the plasma to see what their levels are of folate or iron. If the patient has what disease, they're going to get this.
Pernicious.
If they have pernicious anemia, they're going to get B12 injections. For how long?
Forever.
For the rest of their lives. They go in once a month and get the shot. Okay, oral folate. Now this is the question I want to entertain for just a second or two. If a patient's anemic, they could certainly be treated with a blood transfusion or Epigen, which is synthetic erythropoietin or Procrit. Which one works better? What are the indications for one versus the other?
If they're under 8 and symptomatic, they'll get a blood transfusion because it's faster.
If they're under 8 and symptomatic, they will get a blood transfusion. That is correct. Why can't we use Epigen for that patient? It takes too long. We might not see the effects of Epigen for 10 days to 2 weeks. If the patient is symptomatic with their anemia, we can't wait that long. Now, if the patient has a religious belief that they will not accept blood, you will see them receiving Epigen no matter what, because that's all they'll accept. Okay? So if that's all we can do, that's what we'll do. But the determining factor is, does the patient need blood now? And if they need blood now, we're not going to treat with Epigen, we're going to give them blood. Okay? Exactly correct. Okay, iron replacement might be given, and that can be given, again, they don't even know why the patient has anemia, so they're going to give them B12, and they're going to give them folate and iron. We might see them receiving all those things, just in case any of them might help. Interesting points about iron that you might get on state board questions. What can you give to increase the absorption of iron? Vitamin C. So if I asked you which fluid or which type of item would it be best to give your iron supplement with? Water, milk, orange juice, or soda? Orange juice. And you don't want to give it with milk, actually, because milk could bind it and decrease absorption. So you might get a question like that. Which of the following fluids would it be best to give your iron supplement with? So that vitamin C connection. All right, Polycythemia Vera. This is a situation where you have too many red blood cells. We don't know exactly why this happens in most people. It could be normal for some people who live in Denver or who are Himalayan Sherpas. They carry the big loads at the high altitudes. Why? Because they've adapted and they make more red blood cells. If it's us here in Phoenix, Arizona, it's not adaptive. It would be considered problematic. What we have to look at, though, again, is the volume status. What's going on with the patient's water level, right? Their fluid volume status. Is it possible that we could admit somebody to the hospital in the heat of the summer in Arizona and think they have Polycythemia Vera when all that's really happened is they've been outside all day long and not drink any water? Yes, it is. So before this diagnosis can be made, we have to be sure that the patient is euvolemic, that their volume of water is normal for them. That's important.
But they just moved from Colorado here.
If they just moved from Colorado, it's explained. And after they live here a few years, that will go away in them. Their body won't need it. That adaptation will go away. What's the problem for patients that have Polycythemia Vera? They get thick, sticky blood. They are predisposed to forming clots, intravascular clots. So we want to do things which will decrease that risk. Therapeutic phlebotomy is the treatment. Therapeutic phlebotomy, they're going to remove blood from that patient every month. Or I joke around in classes and say, that's the patient that responds to the leech therapy, right? We could stick a leech on them, which would suck blood out of them, and they'd do better. And I had shared with a lot of you that my grandfather had Polycythemia Vera. He didn't die of it, he died with it, And towards that time of the month when he needed to have his blood removed, he'd get beet red. He'd go in, they'd take out a unit of blood, and he'd be fine. No problem. They never figured out why he had it. It was considered cancerous. Unfortunately, they couldn't use his blood for anything but research. But again, he died with it and not of it. Sometimes it's related to a tumor. It wasn't for him. Okay, leukocyte alterations. Leukocytosis means too many white blood cells. We expect to see that in the face of infection or inflammation. We talked about shift to the left. Okay, this is just reminding us that that would be an overwhelming infection where all of our neutrophils get used up and we are only going to see the babies out in the bloodstream. Leukopenia means that they don't have enough white blood cells, and that's not usually compensatory or ever helpful. In fact, a patient who does not have enough white blood cells is at risk of getting infections. So that's a problematic thing. When the patient's white count drops below 1 or 1,000, that's a patient that we have to protect in the hospital. And we will put them on a precaution called neutropenic, meaning that we have to protect them from us. Good hand washing. Don't take care of those patients if you're sick. No fresh fruit, no flowers. Paper plates, they go to extremes. Visitors, if they're not sick, good hand washing. They can have visitors, but no children. You know, children carry all kinds of good stuff. Now, white count less than 0.5 would be considered life-threatening. When would we expect to see a white count dropping in some of the patients we take care of? Chemotherapy. In a patient receiving chemotherapy, we will steadily see the white count drop over days. And depending on what the chemo's for, let's say it's for a lung tumor, we will try to give them medications which will elevate their red blood cell and white blood cell count while they're undergoing chemo. Remember, chemo kills all rapidly dividing cells. The lung tumor was what we're trying to kill, but in the process, we're killing everything, which would be the bone marrow, rapidly dividing cells. So in those patients, maybe getting chemo for a lung tumor, we can give them Epigen and Neupogen. Okay, Epigen to restore reds, Neupogen to restore whites, while we're trying to deal with a lung tumor. Now, if the patient's getting chemo for leukemia, we can't be giving them Neupogen. That would be trying to stimulate what you're trying to kill. That wouldn't make sense at all. Okay, so it depends on what we're using the chemo for if we're going to be able to work on protecting the patient from leukopenia. Yes?
Did they do that just prior to transplants too?
It depends. It depends on what their goal is. I would think they could probably, it just depends on the disease. Is it a leukemia? Is it a chronic anemia? What is it that they're trying to work with? Is that supported by research? So I guess I'm telling you I'm not really sure. It seems to me that if they're killing down the bone marrow to do a bone marrow transplant, that giving those other stimulating factors might confuse things. I don't know. Anybody working in transplant?
They kill them all down and then they actually have stem cell and then they replace them. You're neutralizing it.
I would think it would be contraindicated to give Neupogen or Epigen when your goal is to kill everything. Because when you're going to do a bone marrow transplant, you got to nearly kill everything they have in order for the new one to take up habitation. The issue is with those patients, in my mind I see a 50-50. 50% of those people are going to have a good result. 50% of them are going to get sick or die because they're so immunosuppressed, that they're going to get something opportunistic. I never wanted to do transplant nursing because you got to be meticulous in your hand washing and your skill. Anything you do wrong, you can kill them. It's significant. It's not the type of nursing I wanted to do. Okay. Lymphocytosis, these are lymphocytes, that particular white blood cell as opposed to neutrophils. And we can see those elevate in viral infections. We talked about that. Or they can drop. Lymphocytes can drop in response to HIV. Other helpful things for you when you're doing your clinical prep, things that make lymphocytes fall out on the CBC can be antibiotics or or steroids. If your patient's on prednisone or antibiotics, you can see your lymphocyte counts drop. So when you're prepping and working with trying to understand those CBC labs that you're looking at, those are things that can cause your lymphocytes to drop out. Okay, leukemia. And this will probably be the last section, other than if I flip towards sickle cell and talk about it for a few minutes. It'll probably be the last section we'll talk about in hematological concepts today. Leukemia means white blood, a situation of white blood. Okay? The issue being one particular white blood cell is produced pretty much to the exclusion of everything else. And the bad news is that white blood cell that's being produced doesn't work right. So how do we find leukemics in the clinical setting? They usually show up with some form of infection. That's how we usually find them. They may have a white count that's through the roof, okay? But those cells don't work right. They're not well protected. So normal white blood cell count, stops at what, 13, 14, and then we start seeing that infection and inflammation zone up to about 30,000. We might see with inflammation and raging infection up there around 26 to 30. Once you get it past about 30, it's not usually infection anymore, and certainly by the time you get to 40,000 or above, you should think leukemia. Infections just don't make them go that high. So if you've got a white count of 40, think leukemia. How do you confirm that? You start looking at the rest of your CBC and you find, oh my gosh, the H&H is low, the red blood cell count is low, the platelet count is low, and all the cells in the differential are low except for one. That's the profile that you'll see on the CBC for a leukemic patient. Okay? Acute or chronic, your acute leukemias usually have to do with a baby cell that's not working right. Your chronic leukemias are usually an adult cell that's not working right, and they can be of myeloid or lymphoid tract. This slide, acute cells, again, early arrest of cell maturation, it's the babies. Chronics are the matures. You don't really need to memorize that. If you want to know the difference between acute and chronic, acute's the babies, chronic's the adults. No matter what, they don't work right. This I wouldn't memorize either. You can look up the definition to those words if you want to. You're going to see those on the chart. The ones we see the most are ALL, kids, acute lymphocytic leukemia. The one we see in adults the most is CLL, chronic lymphocytic leukemia. We talked about this on our med-surg simulation days. That lady that was picking her hair with that metal comb and flossing her teeth vigorously and brushing vigorously. We're all going, no, you're gonna bleed, as she did. She had CLL. Again, those cells that she produced were mature adult cells, but they were not healthy and didn't work right. Clinical manifestations of leukemia. Before we go into that, let's make sure you understand leukemia because it's not hard. Leukemia is when the patient has white blood. They're producing one cell to the exclusion of everything else. White count's going to be 30, 40,000. You start going through the profile and everything is down except for the culprit. In the differential, you're going to find the culprit, right? How do we usually identify these patients? They come in with some form of infection, but why is that? They have a white count of 40,000. They don't work right. They don't work at all.
Do they actually have the infection or the signs and symptoms of the infection?
They have both. They have both. They have an infection and the signs and symptoms of infection. That's how we usually see them. They come in with a pneumonia, or they come in with raging upper respiratory infections. And they don't know why. They're just not getting well. They're not responding to antibiotics and they're not getting well. They run a CBC in the doctor's office because they're failing on antibiotics and we find leukemia. Now, if you understand the patho, you can tell me why almost all of these signs and symptoms occur. Why is a leukemic anemic? They're not producing any red blood cells. All their bone marrow is willing to do is make the diseased white blood cell. That's all it's going to be doing. It's going to exclude everything else. Why is this patient at risk for bleeding? They're not producing platelets. Thrombocytopenia is what you're going to see. Why are they at risk for infection? Their white blood cells don't work right. Okay? Simple as that. They have a whole bunch, but they don't work right. Weight loss usually has to do with the fact that they are anemic and they don't feel like doing anything. They are very tired. The fact that they usually are getting infections, opportunistic things, they're just not interested in eating. Bone pain, this is an interesting one. The bone marrow is actually so prolific, the factory is so busy that it's like bursting at the seams. There is a creation of pressure inside the bones, and so they actually have bone pain. It is so busy in there, bursting at the seams. The liver and spleen enlarge. Why do you think that is?
Absorbing the white blood cells.
Those white blood cells are not right. Okay, the liver and the spleen are trying to remove the cells that are not right. So they become engorged, enlarged. Elevated uric acid, that has to do with the destruction of those cells that are not proper. That's a protein byproduct, uric acid. So, how do we diagnose it? The CBC, and then they'll do a bone marrow biopsy. And that's how they confirm leukemia. It's not hard. I don't think I ever learned leukemia in school. It's like, oh, that sounds so complex, all those words, all those different things. But understanding the patho is really quite simple. Really is. Okay. Treatments, bone marrow transplantation, we talked about that for a few minutes. 50-50 on that. You got to kill everything first before you transfuse. Biological response modifiers, these are drugs of the future. These are the interleukin drugs and things such as that. And combination chemo. Those are also the drugs of the future, the smart drugs. Instead of giving a chemo that kills all rapidly dividing cells, if we can get a few of those disease cells and come up with a drug that only kills that and not the others, that's designer medicine. That's designer pharmacology. Those are what you're going to be dealing with a lot in the future. And me too if I can hang around. Okay. Multiple myeloma. This is a bone tumor. I referred to this when we went over the labs. I'm just going to show you the picture of that particular disease so that you can understand that when a patient develops multiple myeloma, which is tumors inside the bone becomes very holey and full of tumors. That patient usually shows up with what? With a fracture. This is the patient that will have that elevated alkaline phosphatase, ALK-Phos elevation, and calcium elevation. And they will show up with a fracture. Those of you going to Banner Baywood 6 South, you'll see some patients who have multiple myeloma. The profile, again, elevated ALK-Phos, elevated calcium, they show up with a fracture. Good luck repairing it. Do you see any opportunity that you would be able to repair a hip? This is a spine, of course. Those are vertebrae. But think about if your hip bone broke and that's what that was in there. Do you think they'd be able to put a nice prosthesis? No. And by the time we get to these patients, usually they're far advanced. Okay, I want to flip through. I want to talk to you about sickle cell, if I can find it. Sickle cell, autosomal recessive. Autosomal recessive means that you have to have the genetic material from both parents, and then it can present as a disease. Can people become carriers? They can become carriers, but in order for it to present as a disease in an individual, it must come from both parents. Production of hemoglobin S, which is abnormal. Genetic mutation of only one amino acid in the chain. Does it blow your mind? Amazing. No cure for this. The picture tells a million words. That is a normal red blood cell next to a sickling red blood cell. So that when the patient goes in crisis that has sickle cell anemia, more and more and more of their red blood cells do that. Right? A sickle, remember the sickle? They use it to cut wheat. It's an old implement. And so when these cells become stressed, they form that shape, which is like a sickle. How do you think that cell does getting through the capillary bed? The normal red blood cell has to twist. Think about what will happen when that cell is trying to get through the capillary bed. Okay, so sickle cell patients usually do very well as long as they have enough oxygen on board. That's a key to their treatment, is plenty of oxygen. If we have situations of decreased oxygen or dehydration, that can stimulate crisis in patients with sickle cell. Why is it a problem? The vessels can get plugged up. the blood will get thicker, which can stimulate clotting. Circulation slows down, and well, I already said that, clotting. And if we have clotting to our major organs, what's going to happen to the organs? They're going to die. Usually a reversible situation. The treatments for sickle cell crisis are very simple. We give fluid. How does fluid help? It dilates the vessels, especially the capillary beds, so that those sickling cells can go through. And we also know that dehydration is one of the things that causes sickle cell crisis. We give oxygen so that the cells that can carry oxygen well can do that. And we give pain medicine. And these patients have legitimate pain. That is pretty much the treatment that we do for sickle cell crisis. Oxygen, fluids, and morphine. Tell me why you think this patient might show up with jaundice. The liver's going to probably be taking out those cells which are sickling. Okay?
How many sickling cells are they? I mean, they have normal ones, but what's the ratio? Is it different for?
That depends on the patient. The more that are sickling, they won't be carrying oxygen properly, the patient will be more symptomatic.
Do they ever get to the point that that's all they produce?
Not that I know of. And this is exacerbation and remission type situation. Okay?
If the cell sickles, can it go back to normal, or does it just?
I don't know that. That I don't know. Anybody know that? If a cell becomes sickled, can it go back to normal? I don't know that, but I don't know. Okay.